AV guys? Oh, there we go. Thank you very much. Okay, guys. Well, the early bird catches the worm. You guys are here. Hopefully, people will trickle in. I was saying to Dr. Bielamowicz that it's a shame to start at the beginning of a session after everybody's drinking and eating, but hopefully everybody will filter in. It's an honor to have Dr. Bielamowicz here today. He's an associate professor of pediatrics at University of Arkansas Medical School, Arkansas Children's Hospital, in the section of pediatric hematology and oncology. Dr. Bielamowicz serves as the medical director of the Brain Tumor Clinic, the Cancer Predisposition Clinic, and the Innovative Cancer Therapeutics Program at that hospital. His clinical and research interests include clinical trials for disease groups such as pediatric brain and spinal cord tumors, cancer predisposition syndromes, neuroblastoma, and other diseases as well. So thank you, Dr. Bielamowicz, for joining us today.
Thank you very much. Very thankful to have the opportunity to speak to you all. Yeah, before lunch and after a break, those are the worst times, right? People call me Dr. Kevin, Dr. B, hey you. I got a bell of whiskey the other day, which I didn't really understand how that came, but just about anything suffices.
Bell of whiskey?
Bell of whiskey, yeah.
Oh, okay,
that was good.
That's close.
This talk, I'm a pediatric neuro-oncologist with interest in expertise in neurofibromatosis. And so my intention, though, is not to talk to you about results of research but more a conceptual talk of how do I think about treatment options for patients with NF1-related tumors? How do we navigate some of the terminology that's out there? Because everybody has access to a lot of information now, and how do we really how can I help families take that information and really make sense of it? A few disclosures. I will be talking about off-label use of medications and patients who've been enrolled on clinical trials. So I'll be very careful not to talk necessarily about the outcomes in those patients, but really more the thought processes of how we came to the conclusion with the family to go a particular treatment course. I have a couple of more fun pictures of patients, and those families did give consent for those. I do consulting for a company that does work outside of neuroblastoma. So my objectives is that I kind of have a list of terms that I'll kind of go through and really just trying to make sense of those. Some of the phrases or phases of clinical trials that you might see. Use some patient scenarios and decisions to help reinforce some of those concepts. And then really just help you guys look at information that you see online or that you hear about and really try to make sense of that. This is our NF team at Arkansas Children's Hospital. We have a really nice multidisciplinary clinic. And so in the top left is Greg Sharp, a pediatric neurologist. Next to him, Elizabeth Sellers, a pediatric geneticist. They are the co-medical directors of our clinic. Adrian Parkey, who's also a neurologist who works in our clinic. Seth Sorensen is a pediatric neuropsychologist. I often say that he's the most important person of our clinic, just helping families and patients navigate the complexities and the concerns that they have with school and socially. Ariel Westfall is the nurse coordinator for our clinic. As you all probably know, that's who really runs the show and knows mostly what's going on, holds the ship together. We have genetic counselors that come every time we have a multidisciplinary clinic. Leslie Oslitsa is a staunch patient-family advocate who meets with families to discuss a little bit about how can they connect and what are some opportunities to contribute. And then we kind of have some other specialties who have opportunities on the same day to really connect, whether it's ophthalmology or plastic surgery, who does a lot of our neurofibroma surgeries. So that's kind of our team, and then there's me. And so, this was one of the first Sallymet papers for the treatment of plexiform neurofibromas published, back in 2016. And once that data started to come out, families were asking questions about it. And I think it was, and then ultimately, in April 2020, when Sallymet was FDA approved for inoperable symptomatic plexiform neurofibromas, there were just a lot of conversations that I was having to develop, for lack of a better word, a spiel that I would kind of go through with each family about what questions do they have, what are these certain terminologies, what is the role of MEK inhibitors, what's out there as far as topical formulations, and a lot of things that a lot of anticipatory guidance, that I was having to develop and do more and more with families because of their access to information, how the field was just exploding in NF1 related tumors. And so I'm going to kind of walk you through a little bit of that thought process in a little bit more detail. This is a long list of things that I'll go over each of these briefly. There will not be a test at the end because honestly, if you tested me on some of these things, I would probably miss a lot of questions. But anyway, these are some of the terms that I hope to hit on as we kind of go through some particular clinical situations. I'll kind of over and over again kind of come back to the idea of how do we treat tumors. I'll be speaking mainly of tumors that are non-malignant, so benign neurofibromas, low-grade brain tumors. In reality, these are surgical conditions if you can manage them surgically, if that's safe to do with a low risk of long-term problems. Traditional treatments like radiation and chemotherapy, these are a little bit more nonspecific in how they attack things that are growing rapidly. And so chemotherapy for low-grade brain tumors and neurofibromas, not as effective for malignant conditions because those cells are not dividing quite as rapidly. And so that's a good thing that they're not growing like a malignant tumor, but at the same time, it limits the ability of chemotherapy, traditional chemotherapy, to be effective. Radiation can have a lot of long-term side effects, including second tumors from it, strokes that could come up, and those are already things that people with neurofibromatosis are at risk for, and so we really try to avoid radiation unless it's absolutely necessary in people with neurofibromatosis. Immunotherapy hasn't, I just kind of put it up there because it's something that people ask, how can we harness the immune system to really target tumors? And when I think of MEK inhibitors, I put that in a group of medicines called targeted agents. I tell families they can call it their chemo pill if they want to. It's not really traditional chemo, so it doesn't have the typical side effects that you see with traditional chemotherapy. You think of losing your hair, nausea, and vomiting, your immune system being compromised, and it kind of has its own set of side effects. And so it's kind of a separate thing. A little bit, it's medicines that target the pathways that lead to cell growth and tumors, and a little bit different than traditional chemotherapy. And so this is an article that actually a patient family brought me, and I had not seen the article before. And so I was thankful that the family brought it to me because they got to allow me to read about gene therapy in NF1 and related tumors, and I got to educate myself on it. But I think it's just a great example of families having access to information in medical papers before I do. And I like to think that I'm active and participating and being connected, but there will always be families that come to me with information that I have not seen yet. And I welcome that. In this situation, it was a great, this was an article that I'm not going to do any justice to the amazing scientists that did it, but basically they were taking a part of the NF1 gene, they were inserting it into mouse models of tumors and showed that that can actually inhibit the growth of tumors in those mouse models. So, but it was a great opportunity for me to be able to talk to that family that this was an example of a preclinical paper, a paper that is not yet, technology that has not yet made it into patients and for the treatment of tumors, but something that is exciting. There's a lot of this preclinical data coming out, but it's something that was done in a lab, basically. And so I think that is, just a big, families often bring me preclinical papers, and it's a great opportunity to be able to talk with those families about exactly what that means and what might have to happen before that actually makes it into clinical trials with patients. And this is one example of that. And so I do actually bring that up to most families that, there's some stuff out there that's earlier on, and if you read about it, happy to talk to you through where that is and what that might mean and when that might actually be applicable for your child. But they were actually asking if this could be used to treat the tumors in their child. And, of course, it's not quite there yet, but a great opportunity to kind of have that discussion about preclinical data. The next line, which is talking about orphan drug status, rare disease designations, these are amazing resources for our pharmaceutical partners and researchers to really help move along treatments for rare conditions, pediatric conditions, in a way that helps them get to families, patients quicker. As a clinician, the way that I think about these when families often will come excited about something that has achieved a rare disease designation, pediatric disease designation for neurofibromatosis, it doesn't really change how I think about the treatment as far as is it ready for a particular patient. That's really more about what clinical trials are available. Am I able to access the medicine in some other fashion for the families? And so and there are other people here who've given great talks that have gone into detail about those particular things, but as a clinician, they don't really take me in a direction that's different. It's exciting, can talk about that with families, but if something has those designations, it doesn't necessarily make me more able to access the drug, or there are other ways that I kind of think about that for families. So I'm going to go through a few patient cases. I think there's 5 of them, just so you can kind of have as we're going through that, how many there are and where we are in the talk. But this first one is not an uncommon situation, unfortunately, but it's a child that had a very large head and neck plexiform neurofibroma. She was 7 years old. She had problems with swallowing. She had trouble with recurrent ear infections because of it, but her main concern was that it was just physically dysmorphic, and she didn't like the way that it worked, and or the way that it looked, I'm sorry. And so, thinking through, we had watched this grow over several scans with this patient, and the family was ready to do something about it. And so they were not ready to do continuing observation. I think it's very important with these tumors that you touch base with the appropriate surgical specialty. You may be able to help this patient with surgery. And in this case, that was our ear, nose, and throat doctors, and they actually presented the patient at the multidisciplinary conference and really did not think it was in the child's best interest to perform an aggressive resection at that time. Family was interested in medical management, and there were really 2 options at the time. One was a phase 2 trial of Sallymet that was available at other institutions, and another was a phase 1 trial that we had at our institution with cobimetinib. Kind of talked about that, connected with the family with outside institution, and ultimately they chose to do the trial that was close to home. But I use this as an example of a phase 1 study, and sometimes now we're getting, I think most trials are actually phase 1/2, but in reality, the way I think about a phase 1 study is that you're really trying to learn about the proper dosing and safety of a medication. And in this situation, it was a clinical trial that it was a MEK inhibitor, just like Sallymet or some of the other ones that you've heard about, but it also allowed other types of tumors, not just NF1-related tumors, other tumors that MEK inhibitor may make sense for biologically. And so at the end of the day, this patient enrolled on that phase 1 study. It was run through a drug company called Roche Genentech. It was run through a consortium that we had called Poetic, which is a group of 11 children's hospitals. The goals of the study were to find safe and effective doses and to establish a side effect profile in the pediatric population. Now, you are also looking at whether there's a signal or a response in certain patient populations when you're doing a phase 1 study. And so you try to include patients that makes sense for, so that you can then later see if you should move the drug along to later phase studies in a certain patient population. In this particular clinical trial, though, there were many patients who had NF1-related tumors on it, and it was decided that there wasn't a signal of effectiveness to move the drug forward for NF1-related tumors. And so this drug is FDA approved for malignant melanoma in adults, a skin cancer. It's now in phase 2 clinical trials for a rare disease called histiocytosis, both in adults and children. We have a current study at our institution for vascular anomalies but it did not move forward in the NF1 population. So I think a good example of a phase 1 study, we were looking for dose and safety. It included several different patient groups, and it did not move forward in the NF1 patient population. Second case, this was a 5-year-old that had, it was more of like a chest neurofibroma. And with this patient, he had a lot of trouble with breathing concerns, was followed by our lung doctors, a lot of problems with swallowing and pain issues. We had watched it kind of grow over several scans. And so once again, kind of went back to, this was a 5-year-old who couldn't swallow pills. So you have that added layer of complexity, and which of these medications have pediatric formulations, whether it's a liquid formulation or granules, where they can adequately take that medicine in a way that will allow them to have the optimal response. And so in this particular situation, we could have just kept watching this. There were no real emergent or life-threatening problems going on. Family was not in favor of that, and I honestly recommended to try to do something about it as well. The appropriate surgeon for this, I went through several different specialties, and nobody was excited about approaching this surgically, but important to revisit that before you perform any medical management in these particular patients. And then we had a couple of different options for medicines that this patient could take. We did have a local phase 2 clinical trial with a MEK inhibitor called mirdametinib. The study has recently closed to accrual, and we're awaiting results of that, which will take a little bit of time. There's another MEK inhibitor called trametinib that a lot of us have used It has a liquid formulation, so I've used it off-label in particular situations where that makes sense. And so that was an option for this family. But ultimately, they did. There were several studies that were available in other, medicines that did not have pediatric formulations. And so this is kind of how we approached with this particular family what might make the most sense for them. And ultimately, they chose to enroll in the phase 2 clinical trial that was available locally. And so this clinical trial was run by a company called SpringWorks, and it was a phase 2 study. The phase 1 study had already been done, and there was a signal that in plexiform neurofibromas that medicine had been helpful. So they moved on to a very NF1 plexiform neurofibroma specific phase 2 study. So this study, while you're still looking at safety, its main goal was to look at how effective is it in plexiform neurofibromas. And so another complexity, because we had, I think, 5 patients who enrolled on this study, is that the ones who were older and could swallow pills, while this study was ongoing, Sallymet became FDA approved for plexiform neurofibromas that were inoperable and symptomatic. And so just another layer of then kind of went back with those families and said, hey, there's another option now. It is a little further along. There's a little bit more data that's more mature. And I thought it was my responsibility with every family to have that conversation about, if that's something that, we kind of want to think about transitioning at that point, but at least having that conversation that makes sure that they knew that that option was available. And so this is an example of a phase 2 study that a patient went on that was looking at the effectiveness of the drug after having already established the safety and to some degree in a small population, the side effect profile. A third patient case, this is a patient that presented with headaches, nausea, and seizures, had NF1. They had a brain tumor that you can see here. It's right, and I'm sorry that I'm only pointing, but I think you can kind of see that it's this part right here that is not supposed to be there. It was a pretty big tumor in a very tough location. Our neurosurgery team did what we would call a subtotal resection. They maybe took out 40 to 50% of the tumor. In that area, you want to be very careful. A lot of hormones are regulated in that area. Your optic nerves kind of converge at this optic chiasm in that area. We can see kids that you're aggressive at surgery in that area, that they have very poor neurocognitive deficits if you're aggressive in that area. And so it's not a place that you want to be aggressive. And ultimately, this was a low-grade tumor, a non-malignant tumor that was partially resected. And so at that time, had a conversation with the family. Sometimes when you partially resect these low-grade tumors, you can just watch them. If you like it, you like to do that more if it's that you took out 95% of the tumor. It's kind of a more near total resection. In this situation, I think we were worried that in the intricate location of where the tumor was, that less than half of the tumor being taken out, that observation probably wasn't in that child's best interest. And so really we're recommending some type of treatment. Radiation can be very helpful for these tumors, but once again, as we mentioned previously, the side effects of radiation can really be magnified, the long-term side effects in NF1. And so we really try to avoid that in young children in general, but also people with NF1 unless we absolutely need to. We had traditional chemotherapy is used for these low-grade brain tumors. That's probably the standard of care. Drugs with names like carboplatin, vincristine, or vinblastine, and it can be helpful in shrinking the tumors. It doesn't really make them all go away and not come back. And so it's kind of a temporizing measure. Sometimes you can kind of beat it down with the chemo and then they don't regrow. But in reality, it's not, the likelihood that the tumor regrows after that chemo is very high. And so I think it still is our standard of care for medical management in these tumors at the beginning. But we also had a clinical trial that was available through the Children's Oncology Group. Children's Oncology Group is, the largest consortium or group of children's hospitals who treat patients with cancer in this country, and have a clinical trial that's available. This is just, well, I guess first I'll go back and say, I know I'm really talking more conceptually than data, but in this situation, selumetinib is FDA approved for symptomatic inoperable plexiform neurofibromas in pediatric patients with NF1. Selumetinib has also been shown now in a published phase 2 trial to have very good results and activity in pediatric patients with NF1 who have these low-grade brain tumors. And, this is, we call this a waterfall plot. And, if kind of the baseline of this 0 is where each patient's tumor started from a size standpoint, 100% of the patients had some reduction in the size of their tumor because it kind of goes in the negative direction of how big was their tumor. And even though, this line of a 50% reduction is what was considered a response rate, as a clinician, if you tell me that a patient has a 30% reduction in their tumor and they maintain that response, that's a nice outcome. And if that happened with traditional chemotherapy, I'd be very excited. So very nice results in a phase 2 study. But with that phase 2 study, because we have more established treatments with traditional chemotherapy, I think most people, it's still considered standard to use the chemotherapy up front. But we have a current clinical trial that is a phase 3 clinical trial of children at the first diagnosis with NF1-related low-grade gliomas or brain tumors. And the way this trial is set up, it is a randomized trial. And so I think that's hard sometimes for families. I mean, it'd be hard for me if it was my kid to say, I'm not in control of which treatment that child's going to receive. But to some degree, in certain situations, it is the best way to answer the medical question. And so in this particular clinical trial, children with NF1, low-grade brain tumors, at their initial diagnosis, the trial is looking to see how Sallymet as a single agent, single drug treatment compares with probably the most common 2-drug chemotherapy regimen that we use at diagnosis. Medicine is called carboplatin and vincristine. And so it's a randomized study where, you have to commit to being on the study and then be randomized to receive one of those 2 treatments. Now, one way you can look at it is that the traditional chemotherapy is the standard of care. It's the standard arm. And with my families, that's how I still approach with them, that's what we're going to use at the initial diagnosis if you choose not to go on the clinical trial. If you go on the clinical trial, you're either going to get that same treatment, or you can be in the arm which we consider experimental or different, where you're getting the Sallymet in the beginning. And this clinical trial really isn't even, I was not involved in designing the clinical trial, but as best I know from times when I've enrolled patients, and is that they were looking really just to see, not necessarily is one superior than the other, but just is Sallymet as effective as the chemotherapy? And if it is as effective as the chemotherapy, how are the side effect profiles of each of these treatments? Because when you think of traditional chemotherapy with this regimen, you can have nausea and vomiting, you can have hair loss, you can have some of the things that you think of that are not appealing side effects of the chemotherapy. Going to school could be impacted more on the traditional chemotherapy. So looking at all of these different factors, kind of quality of life, symptoms associated with it, in addition to how effective are they. And so this was an example of a phase 3 clinical trial where you were comparing treatment regimens and trying to look, is one better than the other, potentially in several different ways. Now, something I did include on here, but I'm mentioning because one of the previous talks was talking about a placebo-controlled trial. And I didn't put that on there, I guess, just because it kind of exits my train of thought, because in pediatric oncology, there's a lot of ethical questions about whether you can do a placebo-controlled trial. And as far as I can remember, I don't think I've ever been a part of one. And a lot of our drugs are given IV. You're not going to put an IV in a child and give them a placebo in that way. If the medications are oral, that might be for future trials, a future consideration. Blinded studies, if a child is getting IV medicine versus an oral, there's no way you can really blind that. And so I think to some degree, there's the ethics of doing blinded or placebo-controlled trials in children. So that's why I didn't necessarily, in future iterations, if I do this, I'll probably include that. But know that there's some difficulties in doing those aspects of studies in kids. But randomized trial, phase 3. And so, I think of phase 1 trials being man versus drug, phase 2 studies being drug versus disease, phase 3 studies being drug versus drug. And then I put this line in here about compassionate use, expanded access, and emergency access. And these are kind of programs that drug companies typically have set up when they're in between these trials, phase 1, phase 2, phase 3, and there's either there isn't a clinical trial availability for the medication, or potentially a child falls for whatever reason, they don't qualify for a clinical trial for particular reasons. The companies have ways to access medications in particular ways where it's done in a safe manner. And that hasn't happened as much in people with NF1 in my experience. I've had a lot of experience with that in other conditions, but that's kind of where that terminology falls. It's a way to access the medications through drug companies, typically through programs they have set up or an emergency need basis that's done in a safe way with particular protocols. This is a patient, how are we doing on time? Oh, good. This is a patient who presented new to our hospital at 12 years of age, and he had bleeding in the urine. And we did some imaging and found this tumor in the bladder on the left. Actually, only one of this tumor in the bladder. And he very clearly clinically had neurofibromatosis type 1, just hadn't been diagnosed yet. And had this tumor. We actually thought it was going to be a malignant tumor, but we biopsied it and it was a neurofibroma. And got the appropriate surgical service involved, which in this case was urology, and they absolutely did not think it was in the patient's best interest to do an aggressive surgery at this time, because thought that he would have a lot of trouble long-term with urinary retention and things of that nature. And so medical management, this is something where we wanted to move forward with medical management sooner rather than later to see if we could help his acute symptoms. And so this is a patient who presented after the FDA approval of Sallymet. And so really in discussion with this family, something that we wanted to do relatively quickly. This was an indication where the appropriate surgical service had deemed this to be inoperable or not in the patient's best interest. The patient had very clear symptoms from their tumor, and we moved forward with treatment for this child in the manner that it was FDA approved. But you can imagine when Sallymet became FDA approved, there was a lot of families wondering, because some of the headlines you can read are, first drug approved for neurofibromatosis, and that can be really confusing. Can I just take this for my kid and their neurofibromatosis will get better? And so there's been I've really tried to educate families about what the clear role for it is and when we might use it in other scenarios as well. This patient is a 20-year-old. You can see their brain tumor here. It kind of looks like two bubbles in the back of their brain, an area called the cerebellum or the posterior fossa. And this patient, when he was 16, I believe, presented with a brain tumor. He had balance issues, and the tumor we thought was completely resected. And it was a low-grade brain tumor associated with NF1. And in those situations, we just watch it. If a neurofibroma or a low-grade brain tumor, if they can be completely or almost completely resected, typically the right thing to do is just to observe them with serial imaging studies and see if there's regrowth or any new problems that develop from it. And so in this situation, that's what we did. Ultimately, this patient developed a new tumor in the surgical resection cavity where the previous tumor was. And we kind of watched it grow over a few scans, but ultimately recommended intervention. This patient had no deficits currently from his previous surgery, but right after his surgery, he had weakness on one side that limited his ability to do certain things. Those things got better, but in his mind, that surgery was associated with those, and he was really worried that if he had surgery that he might develop more permanent deficits. He was now an adult, and so there was a new dynamic of not that a 16-year-old you would absolutely take into account their perspective and what they want for treatment, but a little bit different perspective as he's now an adult and making a little bit more independent decisions, even though his parents were still involved in the conversations. But when he developed the recurrent tumor, whether it was because something was left over and regrew or it was something new, won't really know, but he developed a new tumor, and we highly recommended surgery again. But the patient was completely against that. And at the end of the day, it's his decision. His parents were in favor of that. We could have done radiation, and we could have continued to watch it as we you always want to think about that option. But in this situation, we had watched it grow over several scans and weren't comfortable. He was going to develop symptoms ultimately, and you don't want to wait in some situations till somebody develops those severe symptoms. Radiation, I offered as an option for the patient because often you can do radiation, it takes 6 weeks and you're done. It has a pretty high rate in these tumors of not having the tumor regrow after radiation. But once again, NF1, other treatment options, you really hate to turn to that with some of the side effects that you can have long-term from it. And so, interestingly, we had a clinical trial available through the Children's Oncology Group, but just the way that trial was set up and the phase or the part of the trial was currently in, if he was 17, he would have been eligible. Now that he was adult, he wasn't eligible for it. And so, they talk about that with the patient. But Sallymet had been FDA approved, and so talked with this particular patient about using off-label use of a MEK inhibitor. And so in this particular situation, we used selumetinib as an off-label medication. And, I like to think that whenever I do that, it's a very thoughtful approach, and you don't want to enter into that lightly. But what off-label means is that a drug has an FDA-approved indication for something other than why you're using it. So in this particular situation, it's FDA-approved for plexiform neurofibromas that are inoperable symptomatic in pediatric patients. This was an adult patient with a low-grade brain tumor. And I did think that it was probably the treatment that made the most sense for this patient. And as long as I think you're having the conversation with the families, but you also have to caution that, there's a chance you might not get it paid for. You have to petition the insurance companies to get the medication approved. Sometimes you have to, have conversations with the insurance company, and it may be that you don't get access to the medication. But this is an example of where we thought that off-label use of a MEK inhibitor for this particular patient was the right thing to do, and ultimately the patient did have a really nice treatment response. But kind of the thought process on how we approach these situations when you don't really have a clinical trial, FDA-approved medication, or an FDA-approved medication, but there's something you might be able to access outside of that. And so a few of those things, we talked about FDA approval. You can read about things having full or conditional or accelerated approval. So sometimes, there's a drug in another condition in the neuroblastoma world that recently got accelerated approval, and that just means that they may have to show a little bit more efficacy data in order to really hold on to that FDA approval. But really what it means is that from our standpoint is if we're using it for the right indication, you shouldn't have any problem with Medicaid insurance companies being able to get access for your patient to those medications. I threw phase 4 studies in there just because it is a thing. I've only been a part of one, but really that's after something has FDA approval, kind of post-marketing, looking at further side effect profiles in a larger group of patients to see if maybe something that you didn't really catch in a smaller group of patients. Last thing that I'll touch on is that optic pathway gliomas are a type of these low-grade brain tumors that occur in people with NF1. It's usually something that happens in younger kids, age 1 through 7. That's kind of the highest risk age range. Pretty common, 15 to 20% of people with NF1 will develop these. The overwhelming majority of those will not need any kind of treatment. You can just watch them if you find them, and if they don't grow and don't cause any problems with the vision, usually you can just continue to watch them. And so there's a lot there. I'll just say that there is a varying spectrum of surveillance practices from just doing eye exams to doing surveillance MRI studies. But and so I won't necessarily, that's a kind of a whole talk in and of itself of, but we have a current clinical trial available that I would call an observational study or a non-interventional study. And so, I think sometimes when you think of clinical trials, you think of, what type of experimental medicine is my child going to receive? Are they going to be a guinea pig, or, what kind of terrible side effects can they have? But in reality, honestly, you've already heard about a lot of studies at this conference that are really not treatment intervention studies, that are just studies where you're trying to observe, learn about a certain particular condition. In this particular situation, we're thankful to be a site through the Optic Pathway Glioma Consortium, which is sponsored by Children's Tumor Foundation, where we're trying to learn about the best way to follow and treat pediatric patients with NF1 who have optic pathway gliomas. And so on this study, any new child that has an optic pathway glioma, a family can enroll that child on the clinical trial. And what it's going to do is basically we're going to submit their clinical information in a de-identified way to the folks who are running the study to be able to collect information on a lot of kids who have that particular condition and try to learn more about, who are the kids that are at risk for having visual problems? Who are the kids who are at risk for having their tumor grow? Who do we really probably not need to do any more MRIs? Are there certain imaging sequences that we can see that might, clue us into this patient is more or less likely to need intervention at some point for that neurofibroma? This study does not have any type of treatment decisions built into the study. So if I have a family that chooses to enroll their child in this study, I make clinical decisions completely independent of the study. It is nice for the family too, because they get to have Dr. Fisher and Dr. Avery, who are running the study, just kind of real quickly look at the scan and say, yeah, I agree that that's an optic pathway glioma. But they have to some degree, realize that this is probably not something that's going to benefit their child in the short term, but hopefully will lead to a bigger impact in the long term. It does require a blood draw one time, so that is something that, but really it's a study that families can help submit their child's clinical information, a blood draw. If they had had a previous surgery, we don't do any procedures to collect tissue, but if they had tumor tissue done as part of a biopsy, they can also submit that to help us learn biomarkers, imaging characteristics, anything that can maybe help us know how to better screen children for this particular condition in a way that will be helpful. So anyway, that's a non-interventional or observational study. So that is all that I have. These are a couple of our NF ambassadors, just more fun pictures to be able to show. But thank you very much for your attention. Happy to field any questions about how I think about some of these clinical situations and terminology.
Thank you very much. That was a wonderful talk. We probably have time for one or two questions. There's one in Hoover. You mentioned that regrowth of low-grade brain gliomas was likely with traditional chemotherapy. Our 4-year-old child received carbo only for a hypothalamic tumor when he was 2.5 years. When studying Sallymet for low-grade gliomas, does quote effective unquote only measure shrinkage, or does it also analyze regrowth? Has it been around, studied long enough to know about the likelihood of regrowth?
Yeah, it's a great question. And I think, with traditional chemotherapy, there are definitely patients, children who do not have regrowth of their tumors after that traditional chemotherapy. And so when I say that, there's definitely a situation for whatever reason, that tumor grew, you kind of beat it down with some chemo and it doesn't ever grow again. And I don't know that we have a perfect feel for exactly who those kids are going to be, but there is definitely a segment of those patients. Clinically, for me, I think, I'm observing that there are definitely a lot of patients that have regrowth after you stop a targeted agent for a low-grade brain tumor. After they, kind of my rule of thumb right now is that you're on it for a couple years. Have a conversation at that point with the family about whether they want to continue to take the medicine based on how good of a response they have, what have their side effects been. But to some degree, the treatment can be indefinite, and that is, I know, tough. But I don't know that we have great information yet as far as what the recurrence rate or the regrowth rate is going to be. But often it is that the target agent just shrinks it. It doesn't make it completely go away. In those situations, it does make you a little nervous to stop. But to my knowledge, I don't think we have great long-term follow-up data yet, but I think it's something we definitely need to collect over time.
And as I mentioned this morning, it's not just tumor, it's also vision that we're looking at least for the optic pathway tumors.
Absolutely.
Any other questions from the audience? Okay, thank you very much. I think we have a couple of minutes before we reconvene, but don't go anywhere because this is a very special panel. So just hang tight. No, thanks.